to tell the consultant or to get the history when there are such variations, and that too sudden variations in an ill patient. Now this is a non-thyroid illness which is throwing up so many abnormalities. So what does it mean? It means that the laboratory which is reporting these has to, as we always say, needs a clinical history. To just authorize these numericals in thyroid, as in many other lab parameters, has to be taken with a lot of caution. Are we in a situation now to address modern clinical and public health needs? Definition of a common reference interval or a clinical decision limit. Do we have that? No, we don't. Are we working towards it? Yes, in certain cases, yes. So the previous slide will tell you what I have just here. Is there a clinical decision level that is being in these illnesses? No. Decision level change and borderline. Would you? Why is it done? If you asked by a clinician, assume that they cause and that's what also has got. So when you have titer, you have a borderline TSH, it is our duty to speak to the clinician or try to retrieve the clinical history from an individual. It may be difficult many a time, but that is something that has to be cultivated. Development of evidence-based clinical practice guidelines are not there as yet because we do not have different cutoffs. Now, from a level of doing routine to understanding a non-thyroid illness to coming to a clinical decision, now we are coming to, do we have cutoffs? And do we need to apply the cutoffs? What the literature or the standard or the people who mean to work on this say, yes, there are varying changes. There are cutoffs at different ages and sexes, but it is not always essential to use them on an everyday practice. They become important in two conditions. One is when you are looking for congenital hyperthyroidism or when you are looking at it in pregnancy. In adults or in elderly people, there are subtle changes. The numericals may vary in an elderly age group. But is it essential that you change your reference ranges in an individual who's 60 to 70? Theoretically and practically and management-wise, in the elderly group, the standing what we cut off give for an adult is good enough. But it is not the same in pregnancy. How many of us sitting in the lab know which trimester of pregnancy we are dealing with when we are reporting these? We really don't know. We presume that the clinician who's referring to us knows. But then we are giving out the normal reference range for these individuals who are in different phases of their pregnancy. And that is something which has got to be altered and looked at. There are really no cutoffs, but there are guidelines how we look at it. And therefore, the advent now is that you check in every trimester these hormones, not at once or at a later stage, because these are clinical decisions which they have to make. And it becomes easy for us to follow these cases because of the electronic patient records that we keep. And that is something we should religiously follow. Whether these needs can be met indeed depends on the availability of laboratory results that are comparable over time, location and across assays. Now we may fulfill these two over time and the location if our patient is a regular one visiting a lab. But across assays, nobody knows when that particular lab has changed its assay. Whether they have shifted from a sensitive to an ultra-sensitive to a high-sensitive. And how many of us really know the difference between these two? They tell you there is a generation change. When there is a generation change, that means either the sensitivity, the specificity, the turnaround time is different. And when you bring these features into being, then that means there may be a reference range change. We are sticking to a reference range which has been quoted, done on some instrument by some generation and then copied onto others. So these are subtle things that all of us in the laboratory have to look at. Now what we forget are pre-analyticals. We just get a thyroid sample, we go ahead and do the test. But if you look at this is a very important thing. And that is why we have moved from doing total T3 and T4, unless in certain situations where it is necessary, we are moving to free. Doing free hormones is much better than doing the total T4 and T3. And what is it that can affect these things? It can be genetic, which is not in our control, drug-induced, and therefore history becomes important, disease-induced, and pregnancy. Altered reference intervals for thyroid hormones, especially TSH, because these are clinical decisions. Childhood, yes, in the first 1 year, the values are high. So if you get an abnormal high value of 24 for TSH, and you put an adult reference range beside it, it seems grossly abnormal. But this is how the children are. They have very high values, usually hovering around 15, 17, sometimes 20 and above, within the first 2 years, and especially in the neonates. So it is very important that you define this, because if we define a wrong reference range, then we may be missing a congenital hypothyroidism. Pregnancy. This is very important, and literature now states that every trimester it should be checked, preferably on the same platform, by the same method, and obviously in the same lab. Yes, changes are there in the elderly, but this doesn't need a lot of change from the normal adult biological reference range. Now, as I mentioned earlier, this is a very important thing, and therefore ideally it should not be tested during an illness. And especially we have to do many things with this. That is, we see more and more in our hospital. The things one sees are very different, maybe to a standalone lab which does not receive hospital patient samples. Now, these antibodies can be there for various reasons, and we are seeing that on analysis patients. So, through time, experience, we improve on our second exposure to such samples. The tragedy is not able to measure, do away with this, because we do not have the proper collection tubes or vacuum cleaners, even by the big companies. They will tell you that not much demand is there in India, and we are not marketing it. There are other simpler ways where you centrifuge, etc., but they may lead to we are not well versed with the procedure. So what does it mean? So, having said that these are interferences, total harm the first line of treatment that we have believed over the years, it means that the best TSH. TSH along with T4 is the ideal way to start looking at a patient who has a thyroid problem. And that is how clinicians or the endocrinologists also look at it. Now, mild alterations in free T4 lead to an amplified inverse response in blood TSH. So, it is always better, because it will be easier to measure a change which is significant in TSH, and therefore that is considered to be the first line of assay that we do. Subclinical thyroid disorders can be diagnosed with abnormal TSH and a normal free T4. So this becomes important that we understand that subclinical thyroid disorders, sometimes only a free T4 is asked surprisingly by clinicians, and then when it is normal, then after a few days, for whatever reason, the patient returns for a TSH. Now this piecemeal sort of an approach would not benefit anybody. So from our own experience and our interaction and people who report these things, the first line of assay ideally should be a free T4 and a TSH. The other advantage that we think of doing a TSH before a free T4 is because it precedes an abnormal free T4. So if the first line is that we do a free T4 and then if it is abnormal, then we will do a TSH, no. A TSH always precedes an abnormal T4 much before time. In reality, TSH FT4 is disrupted, leading to a lot of variable results if a hypothalamic pituitary function is not proper, postpartum patients, non-thyroid illness, early treatment of thyroidism. So even though theoretically, analytically we may be correct, when you want to make a clinical decision, how the laboratory interprets this report is important. And I cannot stress the point that crosstalk with the clinician is an absolute necessity. A lag in TSH reset during transition periods of medication. You will get a lot of patients who say, no, I'm taking 50 milligrams, I've been taking regularly, I have not stopped the drug, I'm taking 100 milligrams. But there is a TSH reset transition periods of unstable thyroid status. This has to be understood by the lab. Now the lab gets very fidgety and panicky when we see very high thyroid TSH levels. And that is when we have to get back to the patient and ask, is there a change of dose? What is it that you are taking? Are there any other drugs? Because this resetting of the TSH in a dose change or hypothyroidism is going to be a schematic representation like this. Because even in a hypothyroidism, when the dosage is adjusted, it takes time for it to fall into the reference. And therefore, history again becomes important to the laboratory when reporting this. I also get panicking. Suddenly this individual has low TSH, then suddenly the T4 is very, very high, then I have to get back to the patient or to the doctor and ask what is happening. So my small message is, don't just shoot out thyroid reports. Please think twice. Pay some attention to it. Try to get history. Talk to the clinician because it means many things. We understand that all clinicians also are not well versed in what the lab does. So it is our duty in the lab to tell people what is to be done. Now, a lot of publications by IFCC and the National Academy of Clinical Biochemistry have come out over the past 10 years, and each one is a gem. Now, the IFCC, as I mentioned, has been working on standardizations, and they have come out with lot of observations. And when you read this, you think, have I been giving out the right report? There are no two platforms that tally. Out of the 16 platforms and 200 to 400 patients that they have tried, only 4 have fit the bill as being harmonized. For the other 12, they had to do mathematical applications to bring them into a proper reference range of acceptability. And out of that, still 2 or 3 failed. So people who know the know-how, who know the mathematics of this, who understand harmonization and validation of different platforms, we will understand that it is very difficult for us in the lab, but we have to make an attempt. We are in an era when we have to cross-talk with the clinician. And just with this slide. This is the same thing that I have been saying. So anybody who is doing thyroid reporting, please see that you read. These papers are gems. They are in clinical chemistry, and they give you a lot of information where we would stand to correct ourselves even in the simplest way. Now, 3 studies, method comparisons, objectives, we talk about all these things, but we really don't think about it when we just buy platforms and automated materials. Since the time is up, I'll just skip these slides.
You have 5 minutes.
Okay. Now, the other most important thing is this is traceability. Now, this is a very important part of whatever we do in the lab. Be it chemistry, be it hematology, be it special proteins, whatever it may be. You cannot just pick up what the company gives you. Those who are into quality and who know about, what should I say, I won't use the word NABL, but who are into accrediting processes will understand that there is something called traceability. A word which we never understood 15 years back, but which we swear by today. Now, this, when you take a material, whether it be a calibrator or any material, please read the kit insert. It is not that I have the best automated systems in my lab, my technicians are very senior, they are perfect, and what they have done is always correct. No. How we choose that material is of utmost importance, and that responsibility lies with us who are sitting at the head of the labs. Now, each substance is traceable. You know that they are certified reference materials. You know that they are second level standards and calibrators that we use. A calibrator cannot be used unless it has a traceability, and this traceability has to come from the Joint Committee of traceability to this. That means that calibrator is not acceptable to be used in calibrator. This is a very right. It is about alternate life ways to have a cutoff. You have to mention on your report map. Put a reference for our pregnancy that will suit, but some and that's it. Because so this is schematic to follow it, but the emphasis that I want to say is please put out a biological reference range when you are reporting the SAGE group. Physiological variables, pathological variables, specimen-related variables. These are things that we have to consider, and we sitting at the helm of affairs have no time for this. But it is something that is to be very seriously taken and considered. And please always report with the appropriate biological reference into it. Now this is antibodies, complex. How often do we get it? We do get it regularly, especially in very ill patients. So if it is positive, immediately it is retreated. There will be a second assay. Please see that you do it same platform by the same methodology and get the clinical history before it is reported. Do we dilute and give an exact figure? I really think it doesn't matter because then you cause more hook effect, etc. Now, these are the various changes that we see when we have thyroid antibodies. So we have to all have understanding of all the parameters in total. And if we do indeed give a wrong report, we have lot of problems. We have lot of problems. We initiate inappropriate treatment, and then we cause so, and finally it takes a lot of time to rectify it for an individual. Thank you very much. I wanted to numericals because I felt if I give numericals, then everybody goes by the numericals. Each lab has its own platform. Every step has their own referencing, etc.
Thank you, ma'am, for such a wonderful insight on this. Can take questions?
Thank you for the wonderful lecture. If yes, it's way forward, but my was similar. And I met a senior endocrinologist who said 3T4 is not necessary. I just look at what I'm doing. So I'm trying to understand that all that endocrinologists, they have their own ways of looking at it. What's your experience? The KAPCON 3T and then they ask for 4 MTS.
I would always